afternoon and hello everyone. Welcome to the Come to the Table Module 4, a pediatric primary care health weight initiative sponsored by the National Association of Community Health Centers. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in our clinical division here at NAC, and I'm pleased to bring in this event along with my division colleagues. Before we get started, I would like to review a few housekeeping announcements. First things first, this Zoom online event is being recorded. This is for quality control purposes. This event will be posted online for playback at a later date. Joining this session automatically consents you to this recording. If you do not feel comfortable with being on this recording while it's live, we ask that you kindly step out of the Zoom room if you'd like. But if you're here and you're okay with that, completely okay. Nothing else for you to do from that perspective. But again, today's event is being recorded for playback at a later date. Audio connections, you either physically called into the meeting or use computer audio. Either option, completely fine. We do recommend, though, that typically if you're in an area where Wi-Fi can be a little bit spotty, using the call-in feature is typically a little bit better, just so you don't hear any of the, if you miss any of the information as we go live. All attendees' audio and video have been disabled for this event. This is really just to avoid any sort of background noise interference. Again, you should be able to hear my voice right now, should be able to see slides on the front of your screen. And just to ensure that you're in the right place, while we go to the next slide, chat box is going to be open for the duration of this event. This lets us know, and you can submit your comments, questions, or concerns into this box at any time. And just to make sure everybody knows where that chat box is at, if everybody could just take a moment and maybe type in the chat box where you're coming from today, and maybe what are you drinking at your desk today. So again, what city and state are you in right now? And then again, what are you drinking, just so we can make sure that everybody knows where the chat box is and it is working completely fine for you guys. Friendly reminders that all audio lines for attendees have been muted and disabled. We ask that you submit your comments, questions, or concerns into the chat box at any time during the event. And there will be a post-event survey, and it will be distributed automatically as you exit Zoom. We'll talk about CMEs in a little while later on throughout today's session. At this moment, I'm going to turn things over to Jenny, who's going to be introducing today's speakers and taking it from here. Jenny, the floor is yours.
Thank you, Liz. Welcome, everybody. I love seeing so many people are coming back on. I don't have anything to drink at my desk. I'm not going to hate on you if any of you have a sugar sweetened beverage. Just, don't have more than one, and keep on that motivation to get it to zero. But anyway, welcome back. For those of you who are coming back, for anybody who's joining us for the first time, this is a fourth in a series. So go back and listen to the first 3 recordings because they do build on each other. There's nothing more fun than having people you admire collaborate with you. And I'm delighted to have Dr. Rick Reifenberg and Dr. Nita Mohanty join us today. They'll tell you a little bit more about their own practices, but both are in CHCs. And Dr. Reifenberg helped us last year as he talked about the medical integration of obesity care and pediatrics into the community health center. And he's going to help us with his tips and models today. And Dr. Mohanty is going to help us with understanding data measurement and the importance of quality improvement in this topic. Not sure what the next slide is. So Liz, go ahead and give us the next slide. Oh, all right. Do you currently prescribe anti-obesity medicine to patients? That's in the new clinical practice guidelines. It's kind of something that most of us are unfamiliar with in primary care. So I know a number of you aren't prescribers anyway, but if your prescribers do, that'd be great to check yes. If you are someone who can prescribe, please do fill out that poll. We'll give you a few seconds to do that, and then Liz will close it out. I'm going to do truth in advertising and tell you that it said that we were going to talk about men, bright bodies, and other health center models. So I'm going to briefly describe men and bright bodies before we go further after the poll. So look at that, 1 out of 43, and that could be Rick, although he may not have been able to do the poll. So Most of us don't, and that will be something that Rick will pay attention to when it's his turn. And excuse me, Dr. Reifenberg, I'm used to first names with everybody. So in terms of bright body and MEND, you can look at, Rick will be after this, you can look those up, but bright bodies is something that's been done out of Yale, and it does follow the clinical practice guidelines. It does do a lifestyle intervention for 26 plus hours with children that includes exercise, nutrition, motivational interviewing, and medical care. And it follows a curriculum called Strong Bodies, I think, Strong something. Anyway, you can Google Bright Bodies and you'll see that. The problem with the curriculum, I mean, it's very good, but the problem with it is proprietary. So it is about $2,500 to engage 20 children with it. And then it's for ages 7 to 16. So it doesn't do anything with our prevention. It is a treatment, and it is for older school age children. You can get subsequent materials once you've made the initial investment for about $400 to continue doing it with groups. But it is proprietary, it is evidence-based, and it has been shown to be successful, but only if you continue it over a very long period of time. The other one is MEND, Mind, Exercise, Nutrition, Do It, also proprietary, but was done through grant funding through a NAC initiative with the CDC, and was morphed into something that we call Commit, because it was less prescriptive in terms of the exact place where you have to do the exercise and the exact, like not providing food or drink to the families, that sort of thing. And we all know in health centers that we need to help families with food and drink and daycare and bringing along the sibling if they need to and that sort of thing. But MEND is also proprietary and also out there as a model that worked. Again, super intensive, more than 26 hours, a focus on exercise, nutrition, motivational interviewing, behavior change, and family-centered. So those are a couple, if you want to dig deeper and know more about them. Those are a couple that have been tested and done in community health centers, as well as the models that are currently being done with NAC and the CDC, and which will have a toolkit coming out in the next year, kind of summarizing those interventions in little baby steps as well as big whole pieces. I'm happy to say that Dr. Mohanty's been part of that, as has Jessica Wallace, and perhaps others of you on the call. So our next speaker is Dr. Reifenberg, and he is a delightful friend that I made through this whole effort. And he runs a both adult and pediatric obesity medical clinic within the walls of his community health center, quite unusual. And he is going to give us tips and pearls from that experience, as well as remind us of some of the overview of what we're doing. So I'll leave it up to you, Rick.
All right, thanks so much, Jenny. Again, Rick Reifenberg, I'm joining you today from Indianapolis, where I'm at the HealthNet Community Health Centers, FQHC. So we're a large FQHC and have patients throughout central Indiana. I will say on my screen, it looks like the slides are also stuck as far as getting, see if there we, so do that and maybe go to the next one. There we go. So there's me, Indianapolis. So I'll just do a few other introductory things. So I'm an internal medicine pediatrics physician, and I'll just say that everything that I'm going to talk about in the next 15 minutes or so is really geared towards people who work in community health centers. So I am not an academician. I am not a researcher. I just care for patients. And I do a half day a week for about 10 years now or so. I have done this community-based weight management program where we see kids and adults. So you can go to the next slide. And I'll go through these real quickly. Just, this just shows what you all know, the rates of obesity have been increasing. And of course, my state, Indiana, is one of those blue ones. And that whole kind of tract through the south central part of the US is where the highest rates are found. And unfortunately, we're part of that. Next slide. In this case today, we're just talking about pediatric obesity, and just the quick reminder is, it's 85 to 94% is considered the overweight, 95 and percent and above of the BMI percentage is considered obesity. And then you can take that even to different class ratings, 1, 2, and 3 of what percent above the 95% that you are, and you can see how those are listed. The CDC has actually come out with some new growth charts that show those lines as well. So just something to keep in mind. It is available, and so most of us in our electronic health record have some way of looking at this in an electronic growth chart. Go to the next slide. And then just, I'm sure all of you are very familiar with this. This is what, the typical patient that I see in my program will look like. And, we have about 9 health centers and about 60,000 patients. And so providers throughout our organization will refer patients to me. But, when in this particular case, you can see this is a patient who's in like maybe 13, but, look where that growth, really jumped up there. So puberty is certainly a really common age that I will see patients in. The other ages are, I see a lot of postpartum women, and actually, women after 50 as well. So what's in common in all those age groups? We just mentioned, hormonal fluctuations, just one of many things that can affect weight. Go to the next slide. I have just one in 23 years of practice. I've had one non-primary obesity, and this was on the left is weight, and on the right is height. This was a secondary obesity. This was a patient who had hypothyroidism. So while we check for that and you make sure they don't have it, in this case, what was the giveaway? Well, their weight is going up percentiles very rapidly, and their height is going down percentiles. And when you see that combination together, that would be the one to look for. Remember that obesity maximizes your genetic growth potential. So typically kids are near the top of the growth charts often, or at least, based on their mid-parental height, it's unusual to see them not attain that or more perhaps. So just some things to keep in mind in the real life practice. And you go to the next slide. So really, this is, as I mentioned, I've done this now since 2012. I see patients 4 and above. We do an intake, and then we try to see them at least monthly for 3 months. But I mean, I've now had patients who I've seen over 10 years in this program. And when I did these slides, they include information from what I see with adults too. But really, those comorbidities, blood pressure, fatty liver, lipid issues, insulin resistance, prediabetes, diabetes, that's all, up through adolescence. You see that all the time. Behavioral health component to it, absolutely. Some of the other things like the joint pains and things like that are less likely to see in kids. But I certainly have adolescents who qualified for sleep apnea and, failed sleep study tests, et cetera. So just the things that we look at. You can go to the next slide. So in this program, what do? We try to use motivational, interviewing. Now, keep in mind, people have been referred to me from within my group. So when they come, it's not, I'm not the one bringing this up. they're the ones who have already been sent and come. But still, it's really important that we start off, with what are the goals? What is it that you want to get out of this program? And we spend a lot of time talking about that. And one of the very first things we get at is the number on the scale is not our number one thing that we're going to be looking at. It will be one of many things. And finding out what's important to each patient makes it go a lot better. So that part's good. We do keep track of weight, height, BMI, blood pressure. In the adolescents, we do a waist circumference and with adults as well. And I have found that one has been very helpful to have as well. Because especially when you have patients who are starting to exercise and really making changes, oftentimes you'll see their weight come down and maybe stabilize, but they're losing inches off their waist as well, because maybe they're gaining muscle mass and all that. And it's just an important thing to be able to show them. It's just another objective number, but it can be really helpful sometimes. So when we see them, a lot of times they've already had labs done, but if they haven't, usually the labs that we will do is a comprehensive metabolic panel, because we're going to want to look at the liver enzymes and some kind of a glucose check. That way we'll do a lipid panel. We'll do an A1C and a thyroid test once. We don't keep following those. Usually those are the only labs that I do. There are more esoteric ones, but it's rare that we do more labs than that. We have a dietitian at our organization who is with me that morning. So the two of us both, she will see the patient and I will see the patient. And then for follow-up visits, we do the same thing. We've created our own program booklet that we use, and if at the end, I'm happy to share that if people want to see it. Keep in mind that's a booklet that's for adults and kids, and most of the information in there is for adults. But just want to mention that. And then we do a monthly health and wellness email as well that we send out. We ask patients if they want to get it, so we go through constant contact. So that's been nice, and it's another way that they get kind of a monthly reminder for me, and it's all automated. So once we start it, we just have to write the letter once a month. So that's been nice to do. You can go to the next slide. And so, over the time, I just want to share some of the real world things that we've done. What I find is, the PCPs have already been seeing these patients. So if we're talking about kids, they've made recommendations. They've maybe had them see the dietitian, and then they're just not making any headway, and they send them to us as somebody who has a little more time to focus just on these. And as sometimes seeing somebody else is another way to get some buy-in. Retention can be a problem, and it's often the first visit. So we find, like, for things like tobacco cessation, it's similar too. You get a lot of people who say yes and want to do it, but then when it comes to showing up for the first visit, that's probably where our biggest no-show part is. Once we've seen them more than a couple times, we actually have pretty good retention, but you basically, that's where you get that buy-in. So that's kind of how we do it. Questions come up all the time that people will ask me about billing, and we bill these under, we use whatever there's usually an obesity diagnosis. It's very rare that we don't have another diagnosis as well. Elevated blood pressure, dyslipidemia, elevated liver function tests. It could be, even fatigue. We'll include those as well. We use standard billing codes. I mean, I consider myself a primary care provider. This is a primary care visit. It's a primary care visit for the disease of obesity. And we have never had issues getting reimbursed for those. I don't know that I've ever had anything denied doing that. So I'll just throw that out there, because again, people ask about that a lot. And then I'll talk a little bit about medication. I mean, we could talk, for an hour on medicines, but I want to give a couple, I think, high level things. I do use medications more in adults than I do in kids, but I definitely have used them in a number of adolescents so far. What I'll say is, from the time I agreed to do this talk till the time that it happened, the AAP just released a whole bunch of new guidelines related to obesity management. And what you find in those is they've had ones before, but they're more aggressive about, especially with adolescents, considering all options when, you failed initial approaches at behavioral management. And that includes things like medications and even potential referral for bariatric surgery. So that's what you're going to find in those guidelines. Now, as we saw from the poll at the beginning, there was, I guess, one person who's prescribed medication so far. And Jenny, by the way, I did not vote in that because it didn't let me vote because they don't let speakers vote. But so it's obvious not many people are. What I'll say is that there's a list of FDA approved medications, and but the fact that something is FDA approved does not mean they're covered by insurance. And in fact, that's probably the biggest issue that we have, is that some of the medications you might want to use, like Wegovy, I have never gotten that covered for the indication of obesity, which is what it's approved for. Never got that approved. Now, if the patient has type 2 diabetes, I can get another GLP-1 agonist, at least this time now in Indiana. About 70% of my patients have Medicaid, which would be similar for a lot of federally qualified health centers. And so I can't get a GLP-1 agonist unless they have diabetes and they're on metformin. But I listed some of the other medications that are often used. So topiramate and phentermine as an example. Now, these medications have been approved for other things. So, and if you look through this, I've got the ages that these medications are approved, not for obesity, but for something else, but just to show like, hey, this medication's been approved for something. So topiramate approved for seizures 2 and above. Phentermine approved, for weight. Now that most states, that's a 90-day, FDA, it's a 90-day approval. Phentermine came on the market in 1959 and has not been changed since then. So so when it got the 90-day approval, nobody has, and it's been generic for so long, nobody has ever made the attempt to get that changed, but a lot of people will use it off-label longer than that. There's a few states that don't allow it, but Indiana doesn't have a problem with it. So that is one that I have used. The one that I probably use the most is metformin. And as you can see, that's, 10 and above. And I will say in kids who there's a lot of pre-diabetics that I have, I don't have a problem at all using metformin in those kids, and it can be helpful sometimes. Vyvanse is one that it has the official approval. Now it's approved for ADHD 6 and above, but binge eating disorder, so now something that we're talking about in an adolescent, perhaps, you could use Vyvanse. So of the medications that I have used in adolescents, what I would say is I've used GLP-1 agonists in the ones who are type 2 diabetics. I have used topiramate and phentermine either independently or together in adolescents, and I've used metformin in a number of adolescents. And then finally Vyvanse, I have some adults with binge eating disorder that I have used Vyvanse with. So just to give you a rough idea, that's kind of been my experience with these. Some of the other information I have in there is more adult related. The other thing that I will say is sometimes I'll come across patients who are prescribed medicines like Vyvanse for ADHD, and then I'll find out they're not taking them regularly. And I'll be like, oh, well, this is a good opportunity. Why don't you take that regularly? Let's go to the next slide. I'll go through the rest of this a lot more quickly because I'm running out of time. The point here is that this comes in the real world. People often don't make appointments to come in just to talk about weight. As you're leaving the room, they're like, oh, by the way, how can you help me be at a healthier weight? You go to the next slide. And when it comes to that, things like this was put out by the AAP a number of years ago, but I love, one page handouts like this that are very straightforward and easy, because when you got your hand on the door, you can say, let me at least give you this. And then why don't you come back and we'll talk about this more. So I have a handout, I have this, and I have one for adults. I think those are great in primary care, because you kind of reel them in a little bit, like, hey, there are things we can do. Let me give you this, and why don't you come back? Next slide. And this part is really kind of the take-home points that I'll just go through quickly. This is something, especially in primary care, if you're the one bringing it up, I think it's great to ask for permission. Is it okay if we talk about weight today? There are some health things that I think this could be important for. Iatrogenic causes of weight gain. There are studies that suggest as much as 20% of now all obesity has some relationship to medications. And certainly in adolescents, Depo-Provera, ones who are on insulin, psych meds, you will definitely see that. The first thing I do when I start reviewing that chart is what meds are they on. The first intervention, as I said, just a simple one-page handout can really be of value just to get them started. And then, taking the dietitian is great with the history that they do and that we help do together. We give them very, very specific goals, and we give them to them in writing. And then next slide, this is the last page. And then in our program, we give them a very specific eating plan. Remember, there isn't one diet that is better than others. The diet that they stick with. So whether it's low carb, keto, Atkins, South Beach, Mediterranean, or a whole bunch of other ones, any of those can be effective. You find what works for that patient. We get everybody trying to be active. We have giveaways. I buy these boxes of jump ropes, and I can give every kid a jump rope. They seem to like that. I go to a below 5 store and buy like soccer and basketballs. So give a kid a full-size ball. That usually gets some smiles. Talked about medications and some things that if they're working, if they're helpful, you really should be seeing 5 to 10% weight loss, and at least or more, and you'll see that in the BMI percentage too. And then we just try to get them to commit to being part of the plan. So that's it. I'm going to stop there because I'm going to take up all the time otherwise, but.
You've been fabulous with your time. It's been really great. And we do have some questions. I had one. Do you think now that the clinical practice guidelines have been published, that insurance companies will have more of a pressure on them to pay for some of these things?
I would like to think so. The GLP-1s are expensive. They're $1,000 to $1,500 a month. So I think we're probably looking at a couple years, unfortunately. But I do think that will happen. But it's going to be a while, I think. I see a question about metformin. Metformin is one. It's interesting. I've taken a class through Columbia that I just finished a while ago, and they had some statistics on metformin. Remember, it's not a weight loss medication. I tell patients that. I said it's one to treat diabetes, and typically these are pre-diabetic or above. And I tell them, you know what, it will help with your blood sugar some, and a lot of people find that it is easier to lose weight. So I don't want them to be like, oh, this is going to be like, oh, I'm going to take it and I don't have to do anything else. It tends to make it a little bit easier. It's worth probably a few percent of weight. And I think the studies show if you have to get them on it and get it up to 1,000 milligrams or more, most likely. So you have to get them to stick with it. But the ones who do it, it often is helpful. So that's what I guess I would say for that.
Thanks for that. Do we have other questions before we transition to?
We do. One from Nicole. Is therapy required for binge eaters when treating with ADHD meds?
Yeah, so it's not, at least in the guidelines that I have seen, it's not absolutely required. Now, I almost always am. I refer a lot of my patients to behavioral health, which again is an FQHC. It's wonderful that we have those services right in-house too. Or often they're the ones sending patients to me sometimes too. So I will say that most of the patients that I have had with that, yes, are also seeing a therapist, but I don't think it's an absolute requirement. And certainly I've seen patients who have been maybe diagnosed, for a long period of time, have done really well on the medication, that they're not necessarily seeing the therapist for the whole length of that time too.
Yeah, I had an adolescent girl who was on Vyvanse for ADHD, but was also a binge eater, right? And so we kind of addressed both. And many of those kids also have depression. So eating disorders and depression go together. So a lot of times you're wanting them to have behavioral health anyway.
Yeah, I found that another group of, I see a lot of autistic kids who are,
Me too.
by the time
Yeah.
by the time they get to be adolescents, they're often on these big gun psych medicines.
Yep.
They have these like ravenous appetites. And I find that for a lot of those kids, Topamax at nighttime often can really help with that part of it, because a lot of them have nocturnal eating too. And so that's one that I have used a lot.
That's a great point. If all of you out there, as we transition to data, if you will look at subpopulations of your children, like those that have autism, because they do tend towards obesity in adolescence, and those that have obviously eating disorders should be paying attention to, but also those with depression and anxiety that can come out in different ways. So be interesting to really look at the combination and your subpopulations. Do we have other questions, Naomi?
Nope, that's all I see.
So I will make a plug for the fact that AAP usually has an annual kind of obesity medicine conference. It's excellent. I really recommend that one. I'll also just recommend Columbia has a great obesity medicine class. And then finally, if you want to do additional education on it, the Obesity Medicine Association, so OMA, Obesity Medicine Association, they have a whole wide range of CME classes for adults and kids that are really, and I've taken some of their classes, and I find that they have some really good resources. So I'll just kind of make a plug for all of those.
Thank you. And
really quickly, there's one more question that came in. Can primary care pediatricians prescribe meds without any certifications? I meant obesity meds.
Yep. Well, I hope so, because I'm doing it. But so when I do use medications off label, and a lot of times I do, I have already pre-written browse options in my EMR that I pull in. I pull up on the screen. We talk about it with the family. We go over everything. So it's documented and in there, and they understand risk benefits. And then we try things. So now, unless there's something specific in your state, but I'm not aware of, there's not a DEA thing, there's not anything else. It's what are you comfortable with? You can start, Up to Date has decent information, the AAP class, the Columbia one that I mentioned, and Obesity Medicine Association. Those are all great places to get CME on this and to where you feel comfortable doing it. Because I wasn't comfortable. I've just developed this over time. I mean, and for the first probably 5 years, I don't think I ever prescribed any medications that I did it. But now I'm doing more and more. And it just so happens that AAP came along and said, that's probably what you should be doing. So
yeah, one of the biggest changes was the AAP saying go to medication early. Don't wait for failure, and for them to get older. Also, like metformin, I think most pediatricians have prescribed that. Topiramate is used for other purposes. You just have to be very aware of side effects.
Yep.
Is there anything else in there, Naomi? We're going to get to you, Dr. Okay, well, let's give a virtual round of applause for Dr. Reifenberg. I'm just so grateful for these colleagues. That I can't say that enough. So Dr. Mohanty is next, and she will give you a few words about what she does as she takes us through the wonders of data management.
Wonderful. Well, thank you so much. And can everybody hear me okay? Yeah, I'm hearing some, I see Jenny nodding and Rick nodding, so I'm going to go with it. Well, it's great to be with you all. As Jenny mentioned, my name is Nita Mohanty, and I serve as the Chief Research Officer at Alliance Chicago. Alliance Chicago is a network of federally qualified health centers, and we provide core infrastructure related to research, quality improvement, and health information technology. I wear another hat that is very, very important to me, is that I'm a community-based FQHC pediatrician, and I practice in an FQHC in Chicago, where I've worked for 18 years, including my residency. So a long time, and they miraculously offered me a job after seeing me as an intern. So there you go. So the next slide is the title of my talk today, which I tried to keep with the Come to the Table theme. So it's a deep dish of data. I live in Chicago. Anybody needs recommendations, I'm happy to provide that as well. So as Jenny mentioned, I'm going to be talking a lot about quality improvement, the purpose of and the value of using data and being a learning health system as it relates to this very important topic we're talking about today. So with the next slide, I'm going to tell a little bit of a historical story. Now, aside from recognizing that this gentleman has probably the best mustache I've ever seen, he is also very noteworthy for contributing a lot to something that we do every day. And he's really, I would say, a father of quality improvement, if we think about it. So he is a physician who practiced in the 1800s. He's originally from Hungary, but practiced in Vienna. And something that he observed in his natural clinical practice was that women who were being treated in the peripartum unit and were treated by physicians were actually having higher rates of sepsis than a group that was treated by midwives. And so this physician's name is Ignaz Semmelweis, and he did a lot of very, very foundational work. But I want to pose a question to the group, to the audience. If you could put in the chat why you think there might have been a difference in the sepsis rates from the physician-treated group and the midwife-treated group. I'm really curious to see what you all come up with. And I'll pause for 30 seconds while people put ideas in the chat. Somebody has to have an idea. This is great. Wonderful. So this is fabulous. So this is really, really exciting that you all went straight to hand washing, which is great. So one of the things that was a really key differentiator between the midwives and the physician group is that the physician group actually would go to the cadaver lab and do dissections on cadavers and teach medical students before going into the peripartum unit. And there wasn't a standardized process for hand washing. And the midwives were not doing that. They were not going to the cadaver lab. They were not doing dissections. They were not introducing those bacteria to their patients. So what he did is he did a very, very, very simple but elegant intervention where he offered a chlorinated solution to both groups, or to the physician group, to see how it might impact what happened in terms of peripartum mortality and sepsis. And what he found is that once you use the chlorinated hand wash, the mortality rates were virtually identical. And he did this very, very, very simply and very elegantly just by measuring with a very simple run chart what the mortality rates are with a very simple intervention. Now, he has a very tragic story. If you ever look him up on Google, his ideas were really not well regarded. You can imagine in the 1800s, physicians didn't like hearing that they were making their patients sicker. And so he unfortunately became a pariah in the medical community. And it was only later that other scientists really introduced the germ theory and had it accepted. And today he is really the hero of hand washing. So a wonderful example of how quality improvement really matters and changes the world. So with that, I will share with the next slide that, we as an organization and as clinicians in general and in healthcare, we really want to be thinking about what are the things that influence quality care. The Institutes of Medicine, I'm sorry, my little thing got wonky there, has introduced some areas or domains that we really need to focus on to provide high quality care. And that's care that's safe, care that's timely, care that's efficient, that's effective, meaning that it uses the best science to inform care, that it's equitable, which is a huge issue in an area close to all of our hearts if we're in community health, and that it's patient-centered. If we convert that to what it's meaningful for patients, we can see how that translates on the right side. But all of these areas are where measurement becomes increasingly important. So with the next slide, I'll share that in our clinical lives, we know, we can advance to the next slide, that in our clinical lives, we know that data and measurement matter, right? We see the infamous stadiometer. We know that measuring kids is very important, but it also measures in a lot of other very important ways. So if we're doing quality improvement, if we want to measure an intervention that we're standardizing, if we want to really have an advocacy and policy agenda for the kids and families we serve, and finally, if we want to impact how these programs get paid for by being reimbursed. So data and measurement really do matter. So with the next slide, I'll give a couple of examples of where we have national data and we have some data from FQHCs. So first of all, we can look at this slide that's published by the CDC. It uses Haines data, and we see the abysmal state of a risk of obesity as it's the worst that it's ever been, right? The highest that it's ever been across all ages. But then I'll challenge you to look at the data I'm providing to you on the right. And this is data we've collected from the FQHCs that participate in the Alliance Network. Those numbers are actually worse if we look for patients in FQHCs, and we know that's for a variety of reasons. So over 50% of patients have a classification of a BMI that is classified as overweight or obese. And while in national data, a cohort says that 1 in 5 of kids will enter kindergarten with obesity, when we looked at our data, 1 in 3 children are starting kindergarten with a high BMI. So this really echoes my previous point that this data is important for policy and advocacy. Our communities experience systemic inequities, and part of this may be individual factors or lifestyle factors or genetics, but there's a huge component of the structural barriers that have been put across our communities that are disadvantaged. The lack of green space, the lack of access to healthy foods. If we don't tell this story, if we don't articulate the needs of our communities, it's hard to garner the community planning, the community resources, the funding to ensure that the case can be different for the kids and families that we serve. So data is so important. There are systemic reasons we need to tell this story. Next slide, please. So to Jenny's earlier point about could we even look at subgroups and say, where do we need to really focus our attention? So let's look at this data set and this data that we produced across the health centers in our network. So this is looking at a date pre-pandemic and post-pandemic to see what happened with BMI greater than the 95th percentile in our populations. This is probably not a surprise to you all because you've seen this anecdotally for the kids that you serve. But to quantify it, let's look at the percentage of kids who have a BMI greater than the 95th percentile. It was already greater than the national averages when we look at the different age groups. But then if we look at the 6 to 12 age group, we see something really concerning in terms of how disproportionately this group was impacted during the pandemic. And one could hypothesize this is a group that was particularly vulnerable for the structural supports that were made available by being able to go to school and being able to have educational time that also allowed for physical activity, structured meal times and healthy meals, and how the pandemic has disproportionately impacted this age group. So these are stories that we need to tell. These are stories that we need to understand. These are ways that we can advocate on behalf of our kids. Next slide, please. So I'll even relate this to just, well, how well are we doing as practices, as clinicians in terms of some of these metabolic risk factor screening, some of the labs that Rick mentioned in his talk. So if we see in 2021, we looked and said, is there opportunity for improvement here? And if we look at some of these labs related to diabetes and also to non-alcoholic fatty liver disease, it seems across the board, there were opportunities to improve across the age ranges from 10 and older to do a better job of screening these kids that is endorsed by multiple guidelines, now the clinical practice guidelines, but even before that, through guidelines from the ADA and through some of the GI professional societies. And that we have an opportunity to see this data and say, okay, there's more that we could be doing here to improve and to do preventive strategies to intervene for some of these conditions early. The next slide, please. So as we're thinking about quality improvement and you're taking some of these ideas and reflecting on what could I change in my practice? What could I change for my patients? I'm just going to introduce some concepts here. So with the next slide, we can say that the whole concept of quality improvement is to use some framework to systematically improve care. I suspect that many people are familiar with the Plan, Do, Study, Act model of doing quality improvement, where you plan an intervention, you do in a short cycle the intervention, you study what the results are, and you make iterative changes to actually refine that process, which is so important. And as Rick shared in his talk, even in intervention, like if you're going to actually start prescribing medications, having a structured way to plan around it, to actually have a plan to implement it, to study what the outcomes are, and then to continuously refine that process. We'll go to the next slide. The other thing I'll mention, and that is something that we think about, is how do we design an intervention that's practice level? And what do we think about in terms of things that can be most effective and least effective? This might be disappointing. It was disappointing to me, but education, while it's the easiest to implement, it's often the least effective unless we're pairing it with other things. Some of the highest or most effective interventions are ones that make it easy for people to do the right thing, right? So you'll see here using things like the EMR, using things like technical interventions like order sets, automating things, making it easy for people to do the right things, may be harder to implement, but they are more effective at creating those interventions. So things like quick text in the EMR, or an order set, or being able to do a referral that's automated, those things have a much more high chance of being effective and sustained over time than maybe just doing a one-off education piece, which is vastly important and should not be underscored. But you may see that there are other interventions you want to pair with it to maximize its efficacy. Next slide, please. And here I'm just sharing some tools. This talk is really more to be a high level, but some of the quality improvement tools, and I'm sorry, my formatting got a little bit wonky here. So the first is a process map. Anytime you're designing an intervention, you want to understand what your current process is and where you could make tweaks to that process and what data you could collect to influence that process. The other is a driver diagram where you think about what are the aims you want to achieve from a quality improvement process and how are you going to change those factors. And the last one is a SWOT analysis, thinking about what are your internal strengths, weaknesses, opportunities, and also threats to any interventions you're going to propose. So there are a million of free tools available online to use any of these. So as you're planning your interventions, I'd encourage you to use them. They're very, very helpful. The next slide, please. And then finally, something that is a very useful thing, but sometimes can be the bane of our existence, which is quality measures. They are very, very helpful because they are a tool that helps us measure a process or an outcome or even a patient experience or a structure. But sometimes we are challenged because they don't always measure what we think is the best thing to measure. So I'll go to the next slide. And I think we're all in this situation right now because we need better quality measures for weight management. I think we have done tons of focus groups with pediatricians and providers who care for kids, family medicine physicians, med-peds physicians, nurse practitioners, and physician's assistants to see what they think about the current weight and physical activity measure. And across the board, people want something different and they need something different. This measure is problematic because it's subject to gaming. There's often an EMR checkbox that just gets checked, or it's non-specific in terms of understanding what is the quality of counseling or physical activity that we're getting and not quantifying it in some way. So I'm sharing the last slides as just an example of things that we're trying to do as a network and collaborating with FQHCs around. So in the next slide, I'll share that there is an entire process for proposing a new quality measure, and we are actively in this process right now. And it's looking at the literature and the research to say what is a good evidence-based measure, How can we get input from FQHC stakeholders to say, does this measure matter? Is it feasible to capture? Is it important to you in your practice? Is it important to your patients? And then we are designing the measure specifications and testing it in the real world. How would this measure look if we actually put it into a real world setting? We have a cohort of FQHCs right now. There's 5 involved in this measure testing pilot where they're piloting 2 new measures. And with the next slide, I'll share what they are because they do relate very closely to certain of the clinical practice guidelines. So this is a bit of an eye chart, but one of the clinical practice guidelines really endorses the screening for metabolic risk factors, including diabetes and including non-alcoholic fatty liver disease. So we're testing what would that look like if that was our quality measure related to weight management. The other one is related directly to lifestyle and behavior change and motivational interviewing. Would it look like if we had a quality measure that measured, are these kids that we're sharing might need some lifestyle counseling? Are they coming back? And are we seizing a next visit opportunity within 8 to 12 weeks to continue the conversation? Because it's not all about the numbers and how they look, but it's also about what are the healthy changes people can make and how can we measure our efforts to do that with patients. So with that, my final slide includes my contact information. I'm always happy to hear from people who care about this topic and always open to questions and ideas. And I thank you all so much for your time today.
Well, that was splendid. It's, a hard act to follow Dr. Reifenberg and then Dr. Mohanty. You just took us right to the top. So thank you. Do folks have questions? Particularly for Nita at this point. We have about 8 minutes left. You all did great with your putting a whole lot of information into a time capsule. Naomi, are there any questions that you're seeing?
Not yet.
I was really struck by the 6 to 12-year-old slide. I mean, that was so powerful. How do you share that at your workplace? Can you tell us how you use that?
Yeah, absolutely, Jenny. We used this with this cohort that we're launching the measure testing pilot with and the quality improvement related work with. So we produced that at a network level and then also been able to produce it at an individual health center level to share and to really encourage the health centers to think about what are interventions we could propose or things that we could do that would be relevant for this age group. The other thing that we have done is back to one of the points in my talk is how do we use this as a policy and advocacy piece? Like how do we use this so that there are more community-based programs for kids of this age that are particularly vulnerable to the structures that are provided in school. Let's hope we don't ever have a situation where we have stay-at-home orders again, but thinking about how we would, really advocate for this age group to have all those same structures in place.
I have one other quick question, and then we have a question for Rick that I'll let Naomi read. But do you ever show parents a chart like that, or just the 6 to 12-year-old? Let's say you have a 12-year-old or a 9-year-old who's really jumped up, just so they can see it's not just me and my family, but it's like this is a population problem right now.
That's a really excellent suggestion, Jenny. In the kind of policy and advocacy handouts that we're providing, we aim to share this at an aggregate level, like these are the trends that we've seen, so that they are patient-facing educational materials. I have not done it at an individual patient level when discussing, maybe when I'm showing a growth chart or whatnot, but that's a really interesting idea.
It's just so powerful visually. All right, we have another question for Rick. Naomi, do you want to take that?
Sure. How do you start the discussion with parents when their child now has a DX of obesity?
Oh, okay. So when you've made that diagnosis, how do you start talking about that? Yeah, no, great question. So, again, in the patients that mostly that I see now, they've already been, they've had some of that discussion already with their PCP before coming to me, but I certainly, I still do regular primary care too, and I will see patients for that. So I usually, it often will come up because we're looking at the growth chart or something else, and we'll just we'll just look at the growth chart and we'll say, okay, we'll see where we're at here. So we're at a weight that's higher than ideal. So why does this matter? And we get into kind of the health discussions in general. And what I tell people when I see them in my program too, that it's called a weight management program, but it's really a health and wellness program. So then we start going through why would this even matter, that your child's at a higher weight for their height, now. And we talk about, well, everything from it's going to be at a higher risk in the future to be at that weight and height. But then we start getting into the medical part of it as well. And we go into the reason why we care, because things like cholesterol and risk for diabetes and high blood pressure and things like that. And remember that health and wellness isn't just the absence of disease, right? It's actually being well, feeling good. And so we talk about, the functional things that go along with that. In kids, you don't have quite the same thing as with adults where maybe they have lost function. But this is where the motivational interviewing comes into. What's important to you? It's just a good question. What would you like to get out of this? If we were going to improve something here, what would it be that you would like to see? And just like that I just stop talking and see what they say. And it's interesting how it can go a lot of different ways, but I love to see, them engage that way. And then when they're struggling with what to come up with, then I'll start making suggestions. But what you really want to get is what they want to get out of it. So I don't know if that's helpful or not, but that's maybe some of the things that I go down.
I think that's helpful. We have another comment, and then we're going to be out of time and have to let you all know about the CME again. But Carl says, I did metabolic screening of obese children for a while, but got discouraged when it never led anywhere. There were minor abnormalities, and my recommendations for weight management were no different. I think, you're following clinical practice guidelines and you're documenting what needs to be documented. If you don't check, you don't know, is what I would say to that in terms of data. And then trends over time, right? Because it's not just a one-time thing. But do either one of you, with the 1 minute we have left, want to answer that?
Yeah, in patients I've seen, the incidence and prevalence of things like non-alcoholic fatty liver disease has actually increased quite a bit over time. Same thing with prediabetes. And in terms of eligibility for medication management, I think it is helpful to know what those labs are. I also have found that for some of our the subspecialty programs that are weight management focused programs that are more of a comprehensive strategy at some of the academic centers that we partner with, the eligibility for those patients to avail some of those services when they actually do have an abnormal finding on those labs actually helps facilitate that referral a bit more.
I'll just add that I usually try to be the ones to share that data with them. And I find for a lot of parents, it's the very first time, like, oh, what do you mean they have prediabetes? They have, dyslipidemia, that their cholesterol is high. At least in the patients that I see, often that's a motivating thing, like, oh, I get it. This is a health problem, isn't it? Now I'm ready to at least try. And no, not everybody does what they're supposed to, guarantee that. But I find it can be motivating to get them to want to at least take one more step along the continuum of change.
And if it's normal or just mildly abnormal, you can use your motivational interviewing to say, what does that mean to you? And then come back with, well, on your side of things, it means we have time to catch this before it does permanent damage. So, you can win either way. We're out of time. Please give our presenters your applause virtually. And Naomi, do you need to say something about the CME credit?
All I'll say is, if you are just joining us for this module and haven't seen the previous ones, you can email me for the link to the previous recorded sessions and resources. Also, if you have any questions for the speakers or questions for any of the NAC staff, you can also email me with any comments, questions, or concerns. So thank you.
All right, thank you everybody for taking time out of your life to pay attention to this. May we all be our children's best advocates and true helpers. And thanks again, Nita and Rick, very much. Take care, everybody.